Hi everybody, welcome to our module on pulmonary physiology. So there's a bunch of smaller topics that all fall under the subject heading of pulmonary physiology, and we'll go through them all in this module. You need to know, especially for step one, about lung volumes and capacities, about ventilation and dead space, about lung and chest wall pressures, and then finally we'll talk about the compliance of the lungs and a little bit about airflow resistance. So let's start by talking about lung volumes. And the first thing to know about lung volumes is the average person can only inhale about 6 liters of air. That's the most you can fill your lungs on average. You also should know that no matter how hard you try to push the air out of your lungs, you will never be able to get the volume down below about 1 liter or so. That air that's always left inside your lungs, no matter how hard you push out, is called the residual volume. Now, when you're not thinking about breathing and you're not trying to inhale deeply or exhale vigorously, that's called quiet breathing. And when you're breathing quietly, your lungs are inhaling air such that they go from about 2.5 liters up to about 3 liters and then back to about 2.5 liters. And this amount of air that's going in and out with each quiet breath is called the tidal volume. That's the amount of air that goes in and out with quiet breathing. Now, if you try to inhale as deeply as you can, you will fill your lungs all the way up to their maximum capacity, that 6 liters amount. That's called the total lung capacity. And that extra volume of air that you drew in above your tidal volume is called the inspiratory reserve volume. That's the amount you can inspire if you try really hard, the extra air beyond the tidal volume. Additionally, if you exhale as hard as you can and push out as much air as possible, you will put out an extra volume of air beyond the tidal volume, and that extra volume of air is called the expiratory reserve volume. And then a final number that I want to mention here is the amount of air that's inside the lungs at the end of a quiet breath, which is shown right here in this picture. That's called the functional residual capacity, and that's a very important volume because that's where the lungs come to rest at the end of a quiet breath. And we'll talk later about how the fact that the FRC is where the forces inside the lungs are balanced, and that's why you end up there at the end of a quiet breath. So I mentioned a lot of things in that picture, so let's review them because they're important. There are 4 volumes that you need to know. The first is the tidal volume. This is the air that goes in and out with each quiet breath. The next is the expiratory reserve volume. This is extra air that can be pushed out with force beyond the tidal volume. And after you push out that expiratory reserve volume, all that remains in the lungs is the residual volume. Then there's the inspiratory reserve volume. This is extra air that can be drawn in with force beyond the tidal volume. And when you inhale the inspiratory reserve volume, the lungs will be filled to capacity. And then finally, there's that residual volume, that air that can't be blown out no matter how hard you try. In addition to the 4 volumes, there are 4 capacities that you need to know, and a capacity is a sum of at least 2 volumes. So the first one is the total lung capacity. This is a sum of all the volumes in the lung, the residual volume, the expiratory reserve volume, the inspiratory reserve, and the tidal volume. The next one is the inspiratory capacity. This is the most air you can inspire. So it's the tidal volume, which is what you inspire with a quiet breath, plus the inspiratory reserve volume, which is that extra volume you can inspire with force. And then the third capacity is the vital capacity. This is the most you can exhale. So this is the tidal volume plus the inspiratory reserve volume plus the expiratory reserve volume. This is everything but the residual volume, which is that little bit of air that you just can't get out of the lungs no matter how hard you try. And then the fourth capacity you need to know is that important functional residual capacity. This is the residual volume after a quiet expiration. It's equal to the residual volume plus the expiratory reserve volume. It's the volume when the system is relaxed, and that means that the chest wall force pulling out equals the lung force pulling in. And this is going to be important later when we talk about these 2 forces and how they balance to determine the FRC. So I'll give you a trick I use to remember the volumes. I just remember them in this order: RV first, then ERV, then IRV, then TV. And if you remember them in this order, then the bottom 2 are the inspiratory capacity, the bottom 3 are the vital capacity, the top 2 are the FRC, and then finally all 4 of them together are the total lung capacity. I don't know if that helps you, but that's how I've always kept them straight. So the next pulmonary physiology topic we're going to discuss is ventilation. So ventilation equals the volume of air you breathe times the frequency of breathing, which is the respiratory rate. So for example, if you took in 500 cc's of air per breath times 20 breaths per minute, that would be a ventilation rate of 10,000 cc's per minute, or 10 liters per minute. Now there are 2 places that all that ventilated air goes. The first place is to the alveoli, and alveolar ventilation is very useful for gas exchange because the alveoli are where red blood cells can pick up oxygen. However, some of that air goes to what's called dead space, and this is ventilation to areas where gas exchange can occur. It's wasted ventilation. So air that goes to the nose and the trachea and other areas with no gas exchange is called dead space ventilation. So let's talk about dead space in a little more detail. As I said before, it's space filled with air, but no gas exchange is occurring. There are two subtypes of dead space. The first is called anatomic dead space, and these are anatomic structures where gas exchange can't occur. And it's basically the conducting portions of the respiratory tract, so it's things like the nose and the trachea. The second type of dead space is called physiologic dead space. This is the anatomic dead space plus volume of alveoli that don't exchange gas. It turns out that not every single alveolus works just right to exchange gas, so some air goes to alveoli but doesn't get used. This is because of insufficient perfusion of blood usually. The apex is the largest contributor because it has less blood than the base. So physiologic dead space is all that space that doesn't participate in gas exchange. It includes the anatomic dead space, but also alveoli that don't work very well. And you should know that physiologic dead space is what increases in many diseases. When the lungs become sick, this isn't going to increase the size of your nose or trachea. The anatomic dead space is not going to change, but those alveoli that don't exchange gas are going to go up, and that means that the physiologic dead space is going to increase. There is a method for measuring dead space. It's not often done. It's an experimental method, and it will determine the physiologic dead space. It's called Bohr's method, and it's an equation that gives you the dead space from three numbers. So first you need the tidal volume. This is how much air goes in and out with each breath. So you have to hook the patient up to a machine and measure the volume of air going in and out with each breath. You also need to measure the amount of carbon dioxide in the air that the patient is exhaling with each breath. And then finally, you need to do an arterial blood gas and determine the CO2 concentration in the artery. Once you know those numbers, you plug it into this equation down here, which says the ratio of dead space, and remember this is physiologic dead space, not anatomic, it's physiologic. The ratio of physiologic dead space to tidal volume is equal to the arterial CO2 concentration minus the expired over the arterial. And this is sometimes done in different disease states to determine if the physiologic dead space has gone up or stayed normal. Next pulmonary physiology topic we're going to discuss are the lung and chest wall. So it's very important that you understand that the lungs tend to collapse. Left to themselves, they want to collapse in on themselves like a balloon that's empty of air and pull inward and recoil and go down into a little pile like a balloon sitting crumpled on the floor. The chest wall, on the other hand, wants to expand. It wants to spring outward. It's got all those little muscles on it, and they want to pull it outward away from the center of the body. So in order to understand the relationship between the lungs and the chest wall, we need to talk about each structure in detail first. So let's start with the lungs. So when the lungs are at rest, they have no pressure and no volumes. Lungs at rest are like a collapsed balloon just sitting there crumpled up on the floor. There's no pressure on the walls and there's no volume inside the lungs. As you start to add air into the lungs, you start to increase the pressure. And you can increase the volume all the way up to a maximum amount when the lungs are completely filled, and then you can't go anywhere beyond that. So this is what the pressure-volume relationship of the lungs looks like. You can just think of that empty collapsed balloon at rest, and then you start to add air and the pressure starts to go up to a maximum value. What's a little trickier to understand is the pressure-volume relationship of the chest wall. So when the chest wall is at rest, it actually has a volume. Even though there's no pressure applied to the walls of the chest, it has a volume because at rest it likes to sit with the walls sort of sprung out from each other, going this way and that way, and some volume of air inside of them. So even though there's no pressure being applied to the walls, they have a volume of air, and this is very different from the lungs that want to have no volume when they're at rest and want to be completely collapsed. Now, if you start to add volume to that chest wall, the pressure will start to go up in a steep line sort of like this. On the other hand, if you apply negative pressure, you try to suck air out of the chest wall, you can start to shrink the volume down almost to zero, but you can't quite get to zero. If you apply very negative pressures, you can get down here close to zero, but you can never get where the lungs are down at complete zero at rest. So you should know that the chest wall and the lungs have a very different pressure-volume relationship, and that's because the lungs want to be collapsed and empty at rest, whereas the chest wall wants to have some volume up here on the curve even when it's at rest and there's no pressure being applied to the walls. When you put the two curves together, you get this green curve right here, and this is the pressure-volume relationship of the entire system of the lungs and chest wall together. And you will see that it settles out to zero pressure at this volume right here, and that volume is the FRC, the functional residual capacity. And that's a very important volume because at that spot, the tendency of the lungs to collapse and pull the system this way is balanced by the tendency of the chest wall to expand and pull the system that way. The forces are in balance, and that's why that's where the lungs settle out at the end of the quiet breath, and that is your FRC. So just to review, because this is an important point, the functional residual capacity is the volume where the lungs in equals the chest out in terms of forces. It's the volume where the lungs come to rest after a quiet exhalation, and inside the system the pressure is zero. There's no increased or decreased pressure from the push-pull of the lungs or chest wall. The pressure inside the lungs at that point is going to equal the atmospheric pressure outside the body. Now let me make a few additional points about the different pressures inside the lungs as a system. Here I've drawn an alveolus right here and the chest wall down here. The pressure inside the alveoli goes from zero to negative to positive as you inhale and exhale. We'll talk more about that in a minute. But the pressure out here in the pleural space is always negative. This pleural space is always having the chest wall pull outward and create a negative pressure in the pleural space. It goes more or less negative when you're inhaling versus when you're exhaling, but it never becomes positive. And that's very different from the alveoli, where the pressure goes back and forth from zero to positive to negative. This makes more sense if you look at it on a graph. So here we've got a pressure of zero, which is the same pressure as atmospheric. And up here on this blue curve is the alveoli. So when you inhale, the pressure inside the alveoli briefly becomes negative, and then air rushes in to fill the alveoli and it goes back to zero. When you exhale, the pressure inside the alveoli briefly becomes positive, and then air rushes out and it comes back down to zero. This is what's happening inside the alveolus. In that pleural space, which is between the alveoli and the chest wall, we are always negative. We become more negative when we inhale because the chest wall tries to make pressure more negative to suck air into the alveoli, and then we become less negative when we exhale, so the chest wall relaxes and allows some air to leave. But key points here are that the intrapleural pressure is always negative because of the chest wall, and the alveolar pressure goes back and forth from negative to positive, settling on zero, and at the end of exhalation it settles on a pressure of zero, and the volume here would be that very important FRC. So let's go back to our graph here of the pressures inside the lungs. So when we say that the pressure is zero at FRC, we mean the pressure inside the alveoli. So I'll draw a little alveolus here, and when we say the pressure is zero, we mean the pressure in here is zero. And because the alveolus is connected to the entire airway and bronchial tree, we mean the pressure is zero in that entire system. And the reason it's zero is because there is positive pressure on the molecules in here from the alveoli trying to collapse, and that is counterbalanced by negative pressure by the chest wall pulling it outward. The two pressures cancel each other out and you get a pressure of zero right here. It's important to understand, however, that the pressure out here in the pleural space is not zero. It's negative because out here you have the chest wall pulling outward and you have no counterbalancing force by the alveoli and the lungs pushing inward. So the pressure is negative in the pleural space. It's always negative in the pleural space. That's a concept that often confuses students, so make sure you have it straight in your mind. Next pulmonary physiology topic we're going to discuss is lung compliance. And compliance basically means stiffness of the lungs. It's very similar in many ways to ventricular compliance in the heart. Compliance means for a given pressure change how much volume changes. In fact, you can calculate the compliance of any structure. If you apply a certain pressure change, that generates a certain volume change, and the ratio of the volume change to the pressure change is the compliance. We don't usually measure it for the lungs, so we don't usually talk about numbers. So that you have a picture in your head, let's talk about what a compliant lung would look like. So this is a lung that's very easily relaxed. It's very easy to stretch. So for a small amount of diaphragm effort, you would generate a small pressure change across the lungs, and this would give you a large volume change. Compliant lungs are lungs where it's easy to move the air in and out. It's easy to stretch them and fill them with air. Contrast that with a non-compliant lung. In this case, you would give a large amount of diaphragm effort to create a big pressure change across the lung, but this would only give you a small change in volume because the lungs are stiff. In non-compliant lungs, it's very hard to move the air in and out. So this is how normal and non-compliant lungs look on a graph. So down here at the bottom we've got the pressure. So as you give a given pressure change, say you go from 0 to 20, for the normal lung you go all the way up here to some high volume right here, but the non-compliant lung you get a much smaller change in volume because that lung is less stretchable and more stiff. So what are some conditions that increase or decrease lung compliance? Well, anytime you get an infiltrate inside the lungs, like pneumonia, that's going to make the lungs stiff. It's hard to stretch them when they're full of bugs and inflammatory tissue. Pulmonary edema, which is wetness around the lungs, can make the lungs stiff. And then if you have fibrous tissue in the lungs, they will become stiff. So all these conditions have decreased lung compliance. You get increased lung compliance in emphysema. So in emphysema, you get destruction of the alveoli and the lungs become very floppy and their compliance goes up. And then also, it's normal to have a little bit of increase in lung compliance with aging. The final pulmonary physiology topic I'll discuss is resistance to airflow. So the boards like to correlate physics and flow mechanics to physiology, and one way to do that is to talk about resistance to flow in the air vessels. So the first thing to know is that the upper airways comprise about 50% of the resistance to airflow. So these are structures like the nose, the mouth, and the pharynx. The lower airways comprise the rest of the resistance, and as the vessels branch and get smaller, the highest resistance to flow comes at the medium bronchi level. And that's because at this branch point there's a lot of turbulent flow, and that creates resistance. The lowest resistance to airflow is in the terminal bronchioles. This allows for very slow laminar flow in the terminal bronchioles, which is good for transmission of air and gas exchange. So if you create a graph of air vessel size going from biggest down to smallest here, and resistance going from low to high here, you get a curve that looks like this. And the peak right here is where you've got the medium bronchi, and the low point way down here is in the terminal bronchioles. And this is sort of a classic physiology curve that's worth knowing for your boards. And that concludes our module on pulmonary physiology.